And action. Hey, folks, welcome to another episode of the Paindora Podcast. This is your host, Dr. Kevin, and I am here with my co-host, Dr. Melissa Cady, who has shrunk herself down to fit in the milieu and have a direct discussion with the COVID virus on why it has really decided to invade our planet at this time. And I'm on the safe stand, and I've decided to actually move off into outer space here. So
that's some social distancing.
I've got some serious social distancing going on.
Well, I'm hugging I'm less than 0.2 microns apparently, or something like that, but you're so very up close and personal.
Right? It just bashes into your face, bang, bang.
Yeah,
bang.
they're just balls running around there. But yeah.
If you don't have a mask to block it, you might as well shrink down so much that it can't get into your mucous membranes.
Right. I do want to learn how to destroy it, but that might take some time.
Yeah.
On a serious note, I know this is changing our lives in ways that no one could have imagined, 6 months ago. That would
6 days ago.
Right, exactly. Well, it really has taken, I think, several of us, even in the medical profession, because I think, we recognize that the immune system is such a critical component. It's not just this, virus, it's how you receive it and how you respond to it that can lead to devastation. And I think it's something that even the last, like you said, last 5 days, I'll say from my point here in fact, I'll show you a little bit. This is 6th Street in Austin. That's shut down quite a bit of, obviously restaurants, bars, gyms. It's pretty desolate. There's one car there. I did a little drive around just so we could, we didn't get outside the car, but we just tried to see what the city's looking like and keep us from getting a little cabin fever. But it really has, to the extent that the governor here in Texas has implemented a law or taken away the restrictions where people can do telemedicine without worries of HIPAA, which is a lot of the privacy, for patients, as long as they're aware that you're doing the best you can using, some type of technology to try to communicate with patients. But it's basically saying that physicians, providers, or at least physicians, can still get paid equivalent to seeing a patient in the office as long as they're engaging in the telemedicine and document appropriately. So there's a lot of things happening on our side. Anything on your side in the Oregon side of things?
Well, we have the side of the shelter in place, and I think the emphasis on telemedicine and things like that is, they've been doing that for probably the last week, kind of pushing hard with that. A lot of triage, obviously, a lot of stuff that just makes, like, it shouldn't have taken a crisis to do this, but really, sometimes I guess it takes a crisis to change and get that inertia out of the way. There's a lot more obviously that needs to be done, but it is kind of interesting how all these really, huge hurdles that people have been complaining about for years all of a sudden evaporated. And telemedicine is a big one. The other one that I think, I haven't followed this super aggressively, but there's this strong push to decrease this licensure requirement for state licensure. And what I mean by that is, if you're a licensed physician, being able to practice now against state lines, because they're anticipating, New York's getting just hammered by this, and they maybe need physicians coming from someplace that isn't inundated yet. And that also brings into it is it doesn't make a lot of sense to have all these individual licensures other than the entire business that's surrounded that, where every state has their own requirements, has their own board, has their own CEs, although they're almost all the same. So it's kind of been kind of stupid is why having all these different state regulatory agencies when you really probably just need one. So that's kind of been interesting,
Right. There is a, I'm forgetting the title of this consortium where they're trying to get where it makes it easier for a physician. Like in Texas, it's pretty difficult or time consuming for people to get their medical license through the board. And I know that Texas is not part of this consortium that's out there where they try to expedite to get a another license in another state. If your primary license is in, one of those consortium type of states, and, it makes it a lot easier for you to get another license. But like you said, there's a lot of things we shake our head about that doesn't make a lot of, logical sense. If you're in the United States and you have a license in a state, with maybe some caveats, you should be able to, it'd be a lot easier to cross state lines, be able to help people in times of need like this, or maybe in a telemedicine type of way. It depends what you're, obviously if you're an obstetrician and have a patient that you need to do an ultrasound on, I mean, it's possible you could help guide someone from across the state line and interpret ultrasound if that was allowed. I know there are some, exceptions with like labs or just reading MRIs or something like that. But still, I think there's definitely, I think this is the beginning of considering the reasonableness of how we're licensing and allowing people to help.
Well, and we really should be amplifying and utilizing the technology that we have rather than practicing a model, trying to shove everything into something that's 60 years behind the times.
Right.
So from, granted, if you're an obstetrician, you're not going to be able to touch the belly and palpate and then do your ultrasound, but you can do routine prenatal care. Right. Instead of having people come into the office, which is a total disconvenience for them, subjects them to risk because they're now coming to a medical facility. Routine care instead would be like, you can do it online. You can do it through some sort of video conference. And then if there was a problem, you can ask them to come in. Now, obviously, if it's a due date for, they have their specific ultrasounds or specific lab or what they have to do, then they would come in for that. But you think from a patient standpoint, how that would change instead of having, 8 prenatal visits and all of them being in the office, in which case you have to take time off work, find a place to park, blah, 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 all that other stuff. Instead, you can actually do that on a more convenient basis for both you as well as the clinician that's involved with this. And then if you think on I kind of think from just like the urgent visits that we have, if you have cough, cold, you're worried about being infected.
Right.
Now, before it was even COVID, what we did was we said, go to your doctor, and more importantly, what they end up doing, because they're booked out with all these stupid chronic care visits for 8 weeks at a time. They're like, well, go to the urgent care or go to the ER or whatever. So then you make these cesspits of viruses and bacteria where everybody's going into these waiting areas sick.
Right.
That makes no sense at all.
Right.
Like none. So why aren't we, I'm hoping in the future, because they're trying to do it now, even with COVID, is why aren't we screening people by video, and then being able to kind of at least ascertain what their symptoms are and then figure out where to direct them next, rather than pull them in, sitting in a waiting room, coughing all over the place, touching everything.
Exactly.
Yeah. So, I mean, it'll be interesting to see what happens out of this, but there's always a little bit of a silver lining, right? It is going to fundamentally change how we deliver healthcare as well as healthcare itself. I mean, there's a whole lot of changes that are going to come from this with healthcare.
Right. And, just the fact that there's a certain level of concern or fear that people have knowing that this is out there, because we know we're trying to flatten the curve by staying home and minimize the stress and strain on our healthcare system, and making some really difficult ethical, just having these ethical dilemmas of who can have the ventilator or not. I mean, we know we don't want to have that, but we know that it's not like this virus just goes away. There's definitely this concern that once people think they can get back to normal, there's still this potential for, other little waves of this. And no one really knows if that's going to be significant or not. But I think people are going to wonder if they have the coronavirus when they get sick down the road. And so, the developing testing, I know there's some articles that are coming out of potentially within 45 minutes a test that's rapid. I mean, I haven't looked at the details of that, but eventually having a rapid test, like we have these flu tests, the typical flu that people have gotten, that, whether somebody is like what they're doing now at our primary care is they say, stay in your car if you really think you need to be tested. If they're able to screen you without bringing you into the waiting room. We're trying to keep everyone away from each other. It makes sense that we have these testing approaches or screening approaches, or even at-home testing if it's something, you know, we can drop ship within the day, to verify what it is before you expose yourself to anybody else. I mean, there's a lot of possibilities that I think the future may be headed in. You know, but it's like a lot of the experts, that this is not just, we're just trying to stem the tide from being so incredibly huge, this first wave, I guess, so to speak. But it's really hard for us to know how long this is gonna, you know, last, and it's gonna change healthcare, and a lot of hesitation too as to when to start seeing people in a way that seems somewhat normal.
Well, and it's gonna be many months, right?
Mm-hmm.
You know, people keep talking about a vaccine, but the problem with vaccines is a coronavirus, and if I'm remembering correctly, coronavirus is the same family as the common cold.
Mm-hmm.
And the reason that we don't have a virus for the common cold is because it mutates, and there's 60,000 strains out there.
Right.
So, you know, we may end up with a vaccine for this specific strain, but again, that's 12 to 18 months down the line if you really want to do it safely, and that's in a good scenario. So this is not going away.
Yeah.
And then, you know, from other healthcare, you know, standpoint, in you're talking about the drive-by testing, you know, or being, that makes so much sense, is examine them in the car. So at least, you know, their car's infected, but you're not bringing them inside.
Right.
The other thing, and I had a discussion with this with somebody the other day, was it should be changing how we assess patients, because this idea of, you know, physical examination is definitely important, but physical examination should be targeted to what it is that you're seeing in front of you.
Mm-hmm.
Like this idea that, you know, you probably learned it in your medical school, I think it was kind of universal, is like, you have to do a complete physical exam on every single patient, blah, 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 blah. That was a different time that came from. And first of all, people aren't the diagnosticians as they were 60 years ago, 80 years ago, 100 years ago, and when they had none of the testing that we have now. Right. And you're practicing and honing that skill. But if you have someone and you're like suspecting that it's COVID, then you want to minimize your exposure. So if they're coughing, then sure, that makes sense. Maybe you want to listen to their lungs. But if you can avoid even that sort of contact, and you know that you have testing and things, and it doesn't make sense, you're going to be, let me listen to your heart as well and do an abdominal exam when that's not in the major complaint. Because now you're submitting the healthcare worker to increased risk. You're not in general providing any benefit to the patient because there's a very specific thing that you're looking for. But we've traditionally done all that stuff, you know, not really because of any patient-specific variables, but because it's required by billing. Mm-hmm. You know, so if you're examining 3 to 5 organ systems, you know, heart, lungs, abdominal exam, skin, all that stuff, you can increase your billing code. Right. And we need to be really evaluating on how is it that we're reimbursing healthcare. Again, are we doing a values-driven approach, or are we doing something that's gamification on how do we check as many boxes as we can so we can maximize reimbursement, whether or not it's justified in this scenario. And I mean, from pain standpoint, I will tell you, if you're in an outpatient clinic, they do like workshops on this stuff, on how you can increase your billing code in a way that you're not going to get, what's it called? Audited, right? So there's the game there. How do you do it in such a way and it's not, again, it's not about patient benefit. It's about maximizing reimbursement. So, I'm hoping that this will change too. And instead of, you know, checking all these little check boxes, it becomes, well, are you examining what you're supposed to be examining? Not a bunch of stuff that you don't need to be examining just because you want to, you know, upcode or whatever. So it'll be interesting to see. I mean, if someone's super sick, it makes sense to see them in their car. And if they're, I mean, I shouldn't say that. If they're not super sick, they're passing out. But I mean, they're sick enough that you're kind of wondering whether they should stay home and eat chicken soup.
If it's infectious.
Just then say, you know, whatever. It'll be it's going to be super interesting the next, 6 to 12 months for sure. It's going to be really interesting.
I think if it's potentially infectious, you know, if you're running a fever, if you're having upper respiratory symptoms, like those make a lot of sense that as a general rule before Corona, that there should be some level of screening and distancing that goes on and protection. And obviously we're recognizing the dearth of personal protective equipment that's out there. My friends who are in, anesthesia and in the surgical realm really have been just not getting what they need. And unfortunately, everyone's scrambling. And so if we, on a global level over the next 3 months, if we can get everything, somehow have the production and manufacturing and the things in place for the next little waves as people try to, play with the idea of getting back into life, so that we're prepared for any other resurgence. Who knows? There's a lot of unknown, but I think the whole point of this episode is to talk about how the changes in healthcare as a result of this. And I think that trying to be pragmatic or practical about how we're approaching our patients is unfortunately kind of the silver lining behind this dilemma, and making us realize what's the real value in healthcare, and how should we judge it, and especially when it comes to billing, like you said. To me, spending time with a patient is quite valuable, but many times that's not even appreciated, that giving time to the patient to actually talk. I mean, the things that I think have been really chipping away at the relationships, especially for chronic illnesses and chronic pain, and getting to the root of those things. Most time in these infectious things, you want to keep it limited to what's only necessary. But I do think it's going to create a shift and a change, and unfortunately, in changes in ways where there's going to be some practices that are going to close, unfortunately. I already know of a couple that are struggling that are beyond 3 months. What's that?
You say practices are closed, unfortunately, but in some ways,
I mean, like permanently closed because of the hit.
Yeah, but I also think that there's going to be a redistribution of how we deploy resources, right? So the healthcare system is going to get completely inundated, and it's going to demonstrate this old model that we had, where we've tried to, the majority of what people are seeing healthcare for is for chronic conditions, and so we've built up this whole thing around that, and now we have an acute episode, and it's going to demonstrate that when you have a bunch of sick people that you haven't really been taken care of for a long period of time, they get extra sick in these acute episodes, and then we start having problems. And really, we're not going to be able to deliver healthcare in that model. I mean, it was going to bankrupt us before; it's going to bankrupt us now. And so, yeah, I know practices are going to go under. I wouldn't be surprised if health systems go under. But I do think there's an opportunity for something else to change. So when we're recognizing that, if outside of this COVID crisis here, that when you're looking at somebody's health, it's less than 11%, if you're kind of trying to pull it out, is actually relevant to acute care, a delivery of healthcare resources. But most of your health is determined by social factors, learning factors, behavioral related factors, right? And so if we were keeping people healthy, and the other kind of interesting about this virus is it's not like SARS. So when SARS, which was 2005, 6 or whatever, it was a while ago. But the scary thing about the SARS virus is it was killing young people because they were having these super immune reactions to it. And as you're younger, your immune system tends to be stronger. The current COVID virus, while we're moving down the chain and getting younger people, it still is preferentially going after people with the weaker immune systems, which is why those over at 65, and particularly those with multiple comorbidities, are at risk. And you're looking at things like diabetes, where we know there's immune impairment, right?
Yeah, and heart disease too.
And heart disease. So you're looking at it in the future, one of the best things that you're going to do when we have this thing floating around is not going away, is going to stay healthy. And so the system is going to actually have to start keeping people healthy so that if they do get infected, they don't have the severe disease, or it's much less likely that they're going to have a severe disease with that. And that is not what our current model does. So again, we're going to see there's going to be a lot of changes. There's going to be a lot of changes.
Right. Inevitably, in the big picture, as our system has been making in a indirect and direct way, making and marketing to people as if they need to be dependent on medical interventions or the medical system, inevitably we've created this problem of them needing us more because of their poor overall wellness. So it's really bit us on the behind, because as a general rule, people, there are a lot of people that could be healthier with different lifestyles and different encouragement, support, and more therapeutic relationships in the medical field, in my opinion. And I think, it's not like you're going to be able to eliminate this pandemic, but I think as a general rule, like you said, if people don't even have to encounter the medical system, then the stress and strain on it wouldn't be quite as big. It's hard to say exact numbers, but I think there's going to be a realization from people that you have to take responsibility for what you can do to help yourself too, not just hope a vaccine comes when we know that this is going to take time. And just like the flu, I've never seen any numbers, and correct me if I'm wrong, but I've seen as low as close to 20% up to maybe 45% effectiveness. These are not exact numbers, but it's never been an overwhelming close to the majority effectiveness of a flu vaccine that was developed from the year before strains. So it's harder, I think, to get a herd immunity in general, or to have the full effectiveness, I should say, against a flu that is mutating over time.
Yeah, they mutate so rapidly, and for the flu vaccine, I think it's the top 3 strains from the year prior, right? So they miss all the new stuff because these little things are mutating all the time, and so it, like you said, it's never perfect. And some years they do a better guess, and other years are not, which is why we have that wide range.
Right.
It obviously does provide some partial benefit, just because there's more than one strain running around, and so it is interesting that. So even if we do develop a vaccine, the likelihood of it having really high efficaciousness to it, like a polio vaccine, is between slim and none. So that's holding out this idea that somehow magic healthcare is going to cure us. And all we're just waiting for that magic moment, just like in the movies, it's like somehow they develop these vaccines in like 2 days in their basement using, somebody's chemistry kit. That's not going to happen. I mean, it's just not going to happen. Again, the little understanding that I remember from microbiology when it comes to viruses specifically, and coronaviruses, is these things mutate fast.
Yeah.
So
it's evolution survival. I mean, it is finding a way to keep itself going, and it'll do whatever it takes. And the ones that can divert whatever attacks we're trying to will be the ones that come out ahead. One thing I want to mention, because I find that this is so common, and I'm not going to mention the 2 drugs that other people have mentioned that have potential for, especially together, causing QT interval prolongation, could cause cardiac death. Like, there's so many side effects from drugs that just throwing these things around without any trials is not very responsible. But in general, when it comes to things like antibiotics, I'm so surprised, even in reading some articles, how people believe that antibiotics, like literally with the flu and stuff, how people don't have the knowledge to understand that antibiotics are typically targeted to bacteria. And it's based on the mechanism of action of, are they targeting like the cell wall? And I'm not saying an immunologist, I did have a microbiology degree in my undergraduate, but that's the whole point, is that viruses, you have to support the system. The best thing is prevention or having a good immune system. But most of these viral things that happen to people, you have to just support them through the process of your body trying to heal itself. And unfortunately, like, Dr. Kevin, you said, is that some immune systems overreact and actually cause damage to the body itself and our own human body. And that damage can cause problems and death. And so those are things to consider. But I I just wanted to emphasize, even though that there might be some modulation or changing or effect from an antibiotic with a virus, it's not, antibiotics are used towards bacteria. That is the mainstay thing there when it comes to antibiotics.
Yeah,
But when it's,
my understanding is when they're using the antibiotics, as they're using them for super infections. So,
Mhm.
you know, for those that don't know, it's like if you get a cold, right? A cold is a virus. Antibiotics don't work against viruses. But when you have that cold, now your immune system drops,
it's
because it's already
vulnerable.
fighting something else. Now you're more vulnerable. And then
Yeah.
there's opportunistic infections. Those bacteria will come in and they can jump on top of you. It's really common with lung type of infection. So people get a viral, like a chest cold or a viral pneumonia, and then as you're compromised, and then the bacteria come in. I actually pretty sure that's happened to when I was in high school and I got pneumonia. I'm almost positive that's what happened to me, because it was like, I couldn't breathe, and then that one like a week, and then then I woke up one day dripping in sweat, like just dripping in sweat, and the whole thing changed. And then I was actually prescribed antibiotics, and then that sort of changed. But it's much better if we can address this upstream
Right.
than waiting for the downstream stuff. Just like anything. And unfortunately, prevention and preparation gets such a short shift. And certainly in the way our healthcare system, it doesn't really facilitate that. And again, while everybody's sitting here, we need ventilators. We need a lot more PPE. Again, personally, I would say do the PPE before we ventilators, because that's, how can we prevent the infection before people are requiring mechanical ventilation? That makes a lot more sense to me. And PPE is cheaper to make than a ventilator.
And that's personal protective equipment for those listening.
That's the masks and the gowns and the face shields and all that stuff, versus a very complex piece of mechanics that requires to be able to deliver positive pressure ventilation to somebody, or put them on a breathing machine. Like, that's a big deal. Making a mask is a lot smaller deal.
Right.
But it's the more we can, just need to think upstream. That's really what we need to think upstream. We need to focus upstream. When it comes to health, you actually have to be doing the things to keep you healthy upstream. Does it guarantee that you're never going to get an infection, that you're never going to get sick? Absolutely not. But I would much rather catch COVID with not a lot of other medical problems, with a pretty healthy cardiovascular system, with no problems with blood sugars because I have diabetes or pre-diabetic state. It's a much better place to be in than sitting on the downstream side, which is what we've done to people. Like, I mean, you mentioned it earlier. What we have basically been prescribing stuff for years now, rather than actually addressing the root for chronic conditions, of the vast majority of which have to do with behavioral and lifestyle change. Are you moving?
Right.
Are you eating the right foods? Are you taking care of stress? Are you sleeping every day? And we just haven't been doing it. And I think, it's sad.
One thing I wanted to add, and just to tie into just the few things we mentioned, is that this idea that sometimes even when parents bring their kids in and they swear up and down that it's bacterial, and finally we know that it usually takes 7 to 14 days plus for these viruses to kind of run their course. And so by the time you see a physician and or just demand to have an antibiotic given, and you think you're feeling better from that a few days later, it very much could have been just your body was that time period when it was starting to get around the curve and get better. So it's really hard to prove to people when they have this belief that the temporal or the timing of they got the antibiotic and then now they're better. Obviously we're talking about viruses here, and they do take time to resolve. And like Dr. Kevin said, there's no better time than now to really take responsibility for your personal health. And obviously the social distancing, these basic precautions that everyone's been speaking of, and washing your hands, avoiding unnecessary contact with people, and wearing special masks. Of course, there's a limit on some of the really good ones, but I'm sure it's being worked on. But there's definitely no better time than now to actually do the things that improve your health. And I'm going to mention a couple things that people don't realize. Most people know that people on steroids, it could be a really healthy marathoner that has a kidney transplant and has to use immunosuppression so it doesn't reject its own organ that it received. But people on opioids long term, that depress your immune system. And these are one of the many realities of certain drugs that are used over a long period of time. And so I know that there's some physicians out there that have already activated information for their patients that if they're having trouble getting, who knows for how long, their medications, even though there's, some laws being shifted so that people can get their medicines, if there is any time to be inspired or find other ways to help yourself with pain, and give yourself your own belief that you can help, master your own pain or find ways to improve it, there's physicians out there that are giving some guidance on how to self-titrate over time. Of course, do that with your own physician, but those are, this is a time for a lot of people to rethink how they're addressing their own medical issues. And I know people could take, have a problem with that, but if it was me, I'd be thinking about that myself, even from a cost standpoint.
Well, you're in the middle of a crisis situation, and this is something that is bugged me for a long period of time, between what I call the difference between an empowering therapy and an entrapping therapy. And people fall into getting trapped by those therapies so easily. But the problem with that is all you need is one little teeny thing to change, and now you're in big, big trouble, right? Because if you are not the one who's in control of the therapy, you're entrapped to somebody else to provide that to you. Mm-hmm. Anything that disrupts that adds an additional stress that is unneeded, and particularly when it's coming to pain. So when we're looking at particularly persistent pain scenarios, we know that active-based modalities, which are the things that you can do for yourself or who you can work with so that you can learn the skills so that you can deliver them yourself, are as or more effective than any passive modality out there. The advantage to them being is you control that modality now. So if I can teach you how to understand your pain, how to approach your pain, how to start deconstructing your pain, and then start taking these self-directed strategies, start addressing those primary contributors that are involved in that process, you can do that without me. And if the healthcare system is like it is now, where all elective visits are being shut down, where you're not going to be getting in to see your doctor anytime soon because the clinics are being closed down in a lot of ways, so that they make sure that they're moving that protective equipment over to these highly acute situations. Doesn't that sound good? I mean, that's what it's like. Well, if I can help you to feel better without me or anybody else, that seems like it's way more valuable from a long-term standpoint than anything else. So, yeah, I thank you for throwing that out there, because people need to, understand that is, the more that you can return control of your care to yourself when something bad happens like this, the less, and this is already a very stressful scenario given what's happening and fears of infection and, the economic fears. That's a lot of additional stressors. If you can just take that one out, take out the concern about needing a specific medication or seeing some specific person every week or 2 weeks or 3 weeks or every 6 weeks, that seems like a gift to me. In no better time than now to really start engaging in that process.
Right. And sometimes it's hard to believe that you can do that until you put yourself through the process, just like anything else, especially if you've, for years been approaching it a certain way. But as we've learned through, whether it's toilet paper or food or, personal protective equipment, that this country specifically is so spoiled with having this easily accessible supply chain. And we don't realize how, when things get turned on its head, how suddenly the supply chain is not providing you with what you want when you want it, with the amount you want. It makes you even think about your own food. Why not learn to start making your own food? Because who knows what's going to happen down the road, or if some type of GI virus, something that's in the food supply, things we're not even thinking about right now. We're just thinking about respiratory illnesses.
Well, some people are thinking about it, because I just read an article today on how beans have become remarkably popular over the last week or so.
Mm-hmm.
dried beans and lentils and all this stuff that used to just sit on the shelves in the grocery
Yes.
store actually getting pulled off. And it was, I'm not trying to make light of a situation, but you got to find them humor where you can. And, it just makes me laugh because beans are a wonderful food.
Yeah.
And learning how to cook them. And I love beans, but and they don't go bad. And now people are like, it was so funny. I can't remember where, maybe it was New York Times, but they're commenting on, they have these like artisanal white pears that are like, or white peach, I don't know, something that, and they're like, no, I'm buying these because they're super expensive and organic. And then the beans, which have been sitting there and they're cheap, they're all sold out. And this bean farmer in California is like, I used to be all alone at the farmers markets, and everybody's buying this stuff.
Yeah.
That makes a lot of sense.
Yeah. Well, you might have some gas if you're not used to eating all those beans, but your gut will eventually get used to it. I'm sorry, I cut you off there.
No, and it's good for your microbiome. And we haven't talked about that ever, but getting all these different foods in there. So, and then you're home, right? And here's an opportunity. People, well, I don't know how to cook. Well, here's your chance.
Yeah, there's
and
YouTube
here's
videos.
This amazing thing. If you have internet, like almost everybody does, and in our region, Comcast actually, if you don't have internet, is giving you like a 3-month free thing because they're
smart.
Yeah, and it is you can learn all sorts of stuff. Like YouTube is amazing. Like I'm not a huge YouTube fan because that's not how I learned. But my kids, man, they just look. If they have a question about something, they look it up on YouTube. And there's even a dedicated channel on YouTube. I think it's curated by Google. It's called like YouTube Learning or something. I should find it.
Oh, that's
I just
cool.
heard about it the other day, and they actually curate all these videos on everything from chemistry to cooking.
That's great.
Yeah, so there's lots and lots and lots and lots of resources out there.
Yeah, I actually, what I found myself doing is going to the store and finding all the weird named vegetables that no one grabs, and just buy them and like figure out what they are, and then find a way to. What's that?
The quarantined orphan vegetable.
Right. And well, and then people like spinach, they're buying up the bag spinach or the frozen spinach, but there was organic bunch spinach, and I'm like, well, I'll just rinse those and I'll put them in the freezer so I can have some greens later. And Swiss chard.
Yeah, we're supposed to be rinsing everything anyway, so we might
right. And yucca, I got some yucca root, and I literally just peeled. Yeah, and I like made mashed potato kind of stuff out of it. I mixed it up with horseradish and chicken sausage, and made like this montage of it was good. It looked really good too, and actually it tasted good. It
sounds really good, actually.
There's nothing but like a little bit of salt and sugar and some kind of. I usually don't use cow's milk much, but occasionally, and so yeah, it was actually it's very good. So I'll have to make it again now that I tried it once. That's the thing. You try it once and then you realize you should just do it again. So
I was just thinking that's the YouTube stations should make is the grocery store of misfit vegetables during quarantine. Right? You walk and just see what's on the shelves, and then have your cooking channel devoted to. Well, look, we have a little yucca. I don't know
what is that? What does it have in it?
Yucca actually has a lot of nutrients. So
yes.
So yeah, it's that's a good one. That's definitely a good one. And actually, probably most of them that you can find are probably the good ones.
Mm-hmm.
Anyway.
Yeah, the things that are common that people, especially the pre-salad kit, pre-made salad kits, those are like off the shelf in most places. But there's ways to be creative and have some kind of novel experience. Not just the novel coronavirus. There's some novel experiences because of it too.
It never hurts to learn how to cook.
No.
I am, and maybe it's not like we had a ton of home ec when I was in high school. I know there was home ec, not a lot of people. I'm not sure how many people took it, but they don't even seem to have it anymore.
Mm-hmm.
And basic cooking skills are sort of like basic survival skills.
Right.
And if you don't know how to cook and then the restaurant's shut down, I guess you're ordering a lot of takeout, but that doesn't, if you really, really want to decrease your risk, you don't necessarily want to order a lot of takeout either, because it's still a transmission there. So cooking, great thing for your health.
And, this topic for this episode is how healthcare or overall, approaches to health are changing because of the coronavirus. But, food is medicine in its own ways. And there's a lot of complexity to that, but you can do your body do bad things to your body if you just constantly eat, Twinkies all day long. I mean, scurvy might be one of them. But there's just so much benefit to sustaining a healthy immune system by what you put in your gut, which transfers, this whole microbiome and affects your brain. I mean, every single cell. I mean, if you think about certain drugs that literally can make your body turn blue, it makes you realize that what you ingest can get into every cell of your body. And there's a couple of drugs out there that amiodarone is one of them. It doesn't happen to everybody, but it just shows you that everything you consume gets, put into every cell in your body. You can actually see it with a pigment on some rare drugs. But yeah, there was something else I was going to mention on the benefits of nutrition.
Well, and I think we've mentioned this before, is just if you could, so much of this stuff, if you could actually package the effects and put it in a pill and then label it, superfoodium or something stupid, right? And got the patent on it.
Yeah.
You'd have a multi-billion-dollar drug, and people don't really comprehend, like losing 10 pounds is as effective as a blood pressure medication. I mean, that just, okay. So you can lose 10 pounds through really diet predominantly and increasing your physical activity, which if you're sedentary is that's not hard to do, to do enough to lose
start walking.
And then lo and behold, you don't need a pill up for the rest of your life. And the side effects are actually good. Because I guarantee if you lose 10 pounds and your blood pressure goes down, you're actually decreasing strain on your heart. You're probably just, those shear stressors, you're not going to have, you're going to probably decrease your risk of having a heart attack for multiple different reasons. You're going to have different perfusion in the areas of the body. You're going to have better glucose metabolism when you're exercising than when you're sedentary. So you have all these positive side effects first, or you can take the drug and get all the negative side effects associated with the drug to treat what you could do with losing 10 pounds. And, so food is a big one. The other, I call them the fundamental four. You got food, eat real food. And this is your perfect opportunity. You go to the grocery store, you find the orphan vegetables on the counter,
right.
beans if they're there, and you start learning how to cook them. Move. Again, another opportunity here is if you're not under house restriction, which I think most of us aren't, you can go take a walk. That's good for your mental health. It's good for your physical health. It's one of the best forms of exercise that you can do. So moving some way every day. The other one's avoiding toxins, and not just viruses and, the COVID is making sure you're not smoking or drinking to excess or using a bunch of drugs, and also making sure you're staying away from toxic environments and toxic people. And then, sleep in restorative strategies where you're looking at stress, you're looking at sleep, you're looking at recovery, all those things. You could do all that stuff right now. In fact, it's in many ways, if you're, granted, there's going to be a lot of financial pressure with this stuff, but if you're home and you're stuck, you can start that process now, and it'll help not only your physical health, it'll help your mental health, and at least put you in a better position when we start emerging from the chaos that we're currently in.
Yeah, I think all of those are awesome ideas. I think the one comment I wanted to make about, there was some concern that kids are going to be out of school and not getting their education. I'm thinking to myself, of all the things that have been dropped out of the public health or the public school education, is some of these real basic concepts. I mean, when kids don't even know where food comes from, I mean, there's so much opportunity to teach them how to change oil in the car, how to do yard work, how to, make your own food, how to prepare your own food. There's so many other lessons in life that are way more practical. Trust me, I've been on all the academic. I get the whole thing that it's good to have structure, and it's good to learn things and to achieve and set those goals and move, have persistence. And, I understand all those things are good, but there's some real basic common sense stuff that, even Dr. Kevin just said, is those are the things that our kids need to be empowered with. And so we can be role models for children out there.
And everything that you just talked about with education, structure, achievement, and not achievement in the bad way, but really self-motivated achievement, where you're just like, you call it effort-based praise, and really setting yourself a challenge that you're overcoming or not. In either way, you're learning really valuable skill sets from it. We didn't talk about that. Maybe we should say that for another podcast.
Yeah, let's do that.
There's a lot of there's some potential for some significant positive change with education around this as well.
I think that should be our next episode.
I would agree with you, because I think, again, in crisis there's opportunity, and there's some big opportunities there from a education standpoint, because that's going to get shaken up in a big way as well. I don't think that's really hit everybody. Well, at least probably in our brains as physicians thinking about that. But man, that there's some big stuff coming there.
And that was a good segue for what I always like to say is the challenge doctors to see change within challenge. And we are definitely at a point of potential for good change, in light of this challenge of COVID-19 and the coronavirus pandemic. But until next time, we will obviously cover maybe some things when it comes to education and our children in relationship to this pandemic. I am Dr. Melissa Cady, here with Dr. Kevin, and looking forward to talking to you in the next episode. Until then, please go ahead, Dr. Kevin.
Stay well and socially distant.
That's right.